Okay, perfect. Okay, so anyway, today, so emergency dermatology. You guys know that we all work in hospitals, do consults. Some of us do inpatient stuff. So this stuff that we see, we kind of got to be able to quickly diagnose clinically, um, in order to approach them in a, you know, in a management issue that's expedited. So you don't delay therapy. You don't typically want to, if you know what it is, you don't want to delay your therapy. There are a few instances, really, that the biopsy should hold you back. And I mean, I suppose one is if you're trying to, you think the patient has psoriasis but might have CTCL, you don't want to try to treat with cyclosporin. I mean, that's a good example. But I mean, if you suspect TEN, most of you have seen it. After this lecture, I would hope that you'd feel comfortable enough to diagnose it clinically in order to approach the diagnosis in rapidly and manage them in an efficient manner. Okay. Same with pemphigus and BP and stuff. And remember, a lot of these immunobullous disorders that we're going to talk about, the management approach is the same. So if you are highly suspicious for an immunobullous disorder, therapy is going to be very, very similar. So the first thing I'm going to talk about are I'm going to go into drug reactions, bullous disease, inflammatories, and vasculitis, and infectious disease. We'll probably get through the first two on this one because the first one's a little lengthy. And it's kind of important because the number one consultation in a hospital are drug reactions. And really, it's not important initially to decipher whether it's what it is, but rather to know if this is a benign or malignant process. And many of you have heard this from me before and from Curdell and people who do consultations and work in a hospital. Your biggest job is to be able to figure out rapidly what the patient has and how it's going to turn out and whether you need to send them home. Because a lot of these patients with like a benign drug rash or severe drug rash show up to the ER and then they go home not really suspecting TN. They come back a day later and you're a day behind in therapy and they're still taking the medication they were taking that they received. So that's your biggest role there. As far as autoimmune bullous disorders, we admit them because they may be super infected, secondary fluid losses, open wounds, theoretical sepsis because they've not been treated, and to get them systemic steroids to get them treated rapidly. Acute pustular psoriasis and PG. Well, acute pustular psoriasis, very much like autoimmune bullous disorders, they can have loss of fluids, they have dysregulation of thermal control. So that's biggest reason to keep them in-house and under control. PG, a lot of times, again, underlying sepsis, osteomyelitis can go hand in hand. LCV, cryo, all that stuff, vasculopathies, they also have underlying problems such as kidney or myocarditis or pulmonary issues that merit their admission to the hospital for high-dose steroids. And infectious diseases like NECFASH clearly need systemic antibiotics and possibly surgical intervention. So when we look at the number one consultation out of a hospital, it's drug rashes. The vast majority of them, I'm going to have to mute someone here. I think I muted everybody. 1 second, please. Make sure you're all on mute because I still hear a few people in the background on occasion. The vast majority are going to be benign drug rashes. Okay? When they're benign drug rashes, you don't necessarily have to stop the medications, and sometimes you don't want to. So you do have to make that difference when you evaluate the patient. And again, that's the vast majority, and that's what they want to know. The consulting physician wants to know, do I have to stop the medication? Is it necessary? And is it from whatever X drug? Okay? But that's the vast majority. There are risks, however, and the risks with drug rashes are life-threatening drug rashes that you guys know, like TN, but also drug-induced hypersensitivity syndromes, which have underlying organ damage. And then you can have associated immunosuppression in conjunction with the drug rash from whatever drug they're treated with. So all this becomes quite complicated, or may become quite complicated. This just talks about 10 to 30% of inpatient consultations are drug rashes. Most common are the antibiotics. The vast majority are morbilliform or benign. And again, your job here is to figure out, is this a severe life-threatening disorder? The most common reactions, as you can see here, more common, morbilliform. Then you can have urticarial. Vasculitis can also present as, secondary to medications. Benign morbilliform drug interactions are type 4 CUMs. They're basically cellular immune system where you have CD4 and CD8 T cells recruited, and their cytotoxic activity leads to damage to keratinocytes. Most common is antibiotics. These drugs usually cause a rash within 7 to 14 days after starting the medication and can resolve 1 to 2 weeks after stopping. It will start a little bit faster if it's a re-challenge and they've had a prior rash. Not infrequently, in benign drug rashes, you'll have flexural areas that are spared. And even if you continue the drug, and this is important because HIV can give a morbility of HIV drugs, like a Bacavir, can give a drug rash, and you don't want to stop it, okay? I'm not sure if I go into this, but if you stop a Bacavir and then re-give it, there's a theoretical possibility that they will, the second time around, go into a hypersensitivity syndrome. I think I go into that. And you have to have criteria before you stop these drugs. On rare occasions, they'll become erythrodermic. This is just your pretty classic morbilliform drug reaction. The biopsy, this is not a specific thing. It's helpful, and it's just an urticarial reaction on occlusion. You'll have mixed patterns. This is not infrequent in drug reactions where you'll have like kind of an urticarial reaction, some spongiosis, and even focal interface changes. That when you get these mixed inflammatory patterns, what I refer to mixed, I mean interfacey, urticarial, sponge, with the eosinophils, that really kind of like raises a red flag to the potential possibility of this being a drug reaction. I was going to mention, occasionally they'll have dyskeratotic keratinocytes, not always. That doesn't exclude that possibility. And just because you don't have, or if you don't have eosinophils, does not exclude the possibility of a drug reaction either. Now, let's go to this here. This just looks at drug eruptions in general, and you can have many types of clinical findings on or clinical presentation with drug eruptions, maybe macular papular, blistering, urticarial, pustular, purpura, photosensitivity, and they all can have associated malignant forms. Okay, DRESS is a malignant form. TN, Stevens-Johnson spectrum, is a malignant drug eruption. Drug-induced hypersensitivity is a malignant form. Linear IgA, EBA, serum sickness, AGEP, these purpura fulminans-like and vasculitis-like spectrums, and lupus, either systemic lupus erythematosus or subacute cutaneous lupus erythematosus, both can be drug-induced, and these would be considered their malignant counterparts. Now, the first spectrum I'm going to talk about, the malignant forms, and even though EM can be caused by herpes virus and Stevens-Johnson's has mycoplasma associated, their primary cause are medications, okay? And when you look at the classification of this form of malignant drug reactions, they're basically based on the percentage body area of detachment, okay? How much skin is detached. Erythema multiforme, the major, tends to be less than 10%. These have typical targets in mucosal involvement, whereas when you get the Stevens-Johnson syndrome, overlap, and TN with spots, TN with spots basically means they're not erythrodermic and not edematous, whereas without spots means they're erythrodermic and edematous. Even though they can be less than 10% in Stevens-Johnson's, they'll present with atypical targets that we talked about. You know, a typical target is the center is red, then you have a little area of whiteness or ischemia, and then surrounding that, you'll have more erythema, an annular ring of erythema around that. That's a typical target, okay? Now, Stevens-Johnson's less than 10%. Overlap will be 10 to 30%. TN with spots greater than 30%. If you're erythrodermic, then you just have to be greater than 10% without spots. This is the real deal. This last one is the real problem to us. Just checking my... Okay. Erythema multiforme overall is self-limited. It can be recurrent, okay? Typically in young adults, male more than females. The main precipitating factor is herpes simplex virus 1 and 2, although there are others. And there have been drug-induced forms. There are HLA associations here, as you can see, and that's probably on your handout. 50% have preceding herpes outbreaks, okay? And the will occur, you know, within 2 weeks before the clinical presentation of erythema multiforme. And this just shows the mucosal involvement that you'll see. Remember that, you know, it's not just oral mucosa. It's, you know, ocular mucosa, vaginal mucosa, perianal mucosa that you need to kind of make sure that you evaluate and that you don't miss in that subset of patient. Now here's a very good typical target right here. You'll see the red center, the white, and then the red surrounding. On occasions, the center will blister, but you still have that erythema around with the white and then the erythema around. That's a typical classic target noted in erythema multiforme. Not infrequently involves acral sites. They cadnerize. There's typically no prodrome or no systemic symptoms, but you know, if the patient, this is the first exposure to herpes, they do develop it, you can get a viral kind of viral syndrome associated with fever. Typically, this is self-limited. These patients don't die. It's more of like a pain in the rear end, as they say. And there are associated recurrent variants of erythema multiforme. When you work them up, you could get a CBC. On occasion, eosinophilia will be noted. CMP helps, renal function. HSV titers for IgM, HSV 1 and 2, IgM and IgG. Now, not infrequently, people will have raised IgG levels, but IgM is a red flag. Bacterial cultures, some areas can be super infected. And then Zank smears. These just all show Zank smears that you'll see some of the blistered areas, possibly the mouth, of erosion in the mouth where you see multinucleated giant cells on the smear in a glass are stained with Giemsa, which most of you as residents working with us will eventually be doing this on a pretty frequent basis. You guys don't need to see this. This is not for here, but in erythema multiforme, what you'll see is confluent or at least buckshot pattern of dyskeratosis. It's a rapid acute onset, so typically the stratum corneum will be spared. You may or may not have eosinophils. This, when they do have eosinophils, has been suggestive. This actually has eosinophilic spongiosis on this one corner here. That's suggestive of a drug, possibly, you know, doesn't mean definitively. Spongiosis, again, mixed pattern. You'll see this in drug-induced forms of rashes in general. You might get from so much dyskeratosis along the basal layer of the epidermis, you'll also be seeing subepidermal bulla on occasion. But typically what you'll see is this bottom right picture where you see full thickness or almost full thickness necrosis of keratinocytes. You'll see dyskeratotic keratinocytes present here in pink throughout a viable epidermis. There's even vacuolopathy, vacuolar change, okay, along the dermal epidermal junction. The diff is nonspecific. You pretty much should do a diff here to rule out immunobullous disorders, but I mean, we don't typically use diff to diagnose erythema multiforme. It would be an ancillary study of some help. However, it is not diagnostic of this entity. You can do HSV antigens and PCR, but you can also do them with IPOX and in situ hybridization studies. Now, the therapy for this is pretty mild. You don't have to be too aggressive. Oral antihistamines, oral antacids for oral lesions. I'll get to the systemic steroids in a second. Antibiotics if secondarily affected, and topical agents. Now, as far as systemic steroids are concerned, I don't like this comment. If you suspect it being drug-induced, yes. Okay? But if this is a recurrent process, and you don't suspect that it's drug-induced, you suspect it's herpes-induced, and you're giving them antivirals that we'll talk about in a moment, no problem giving systemic steroids. I mean, there are papers even using anti-TNFs with systemic steroids and antivirals. This is just oral care. We use a magic mouthwash that contains Kenalog, which is triamcinolone, nystatin, Maalox, and an antihistamine. And then you can use, this is more for sterilization, hydrogen peroxide and water 1:1, and viscous lidocaine more for pain. Now, these patients should receive antiviral therapy, and I'm not going to go into the details of this. You can open up any Hippocrates and find your information, but you'll see if it's primary, secondary, suppressive, or recur, the dosage that you need, if it's immunocompromised or not, depending, on that patient, what the dosage should be. So this is a cyclovir. Here's famciclovir, similar, valacyclovir, same kind of spectrum, okay? Now, Stevens-Johnson's, on the other hand, is, and by vast majority, drug-induced, although it can happen in childhood and has been associated with, infectious disease we'll talk about. Recurrences are rare. They get it, and it doesn't come back, on the contrary to erythema multiforme. 6 cases per million, so more than TN, which is 1 case per million, associated with their appropriate HLA, which you should know. And the most common drugs are, NSAIDs, anticonvulsants, sulfonamides, tetracyclines, and penicillin. These associations have been documented. BCG vaccine, viral, include enterovirus, adenovirus, measles, mumps, influenza, fungal, histoplasmosis, cocci. Bacteria, the big ones, Mycoplasma and Legionella is not on here. Mycobacteria, Treponema, and Chlamydia. Okay. Now, when you see, let's assume that this is severe drug rash. Okay, patient comes in, and before we get into all this stuff, what are markers? And it's not in, I don't know if I have this as a separate slide, maybe I don't. But when you evaluate a patient that has a benign or severe drug rash, you're contemplating, does the patient have TN? Do they have DRESS? You have to make sure that you evaluate certain things. These things include, and I'm going to start this now because we already did the benign drug rashes, but things that should be red flags, and you should document when you call your attending, or you're speaking with another resident, or you're speaking with a colleague or a nurse, or you're trying to convince your consulting physician what it is. These are the red flags. Fever, okay, itchy or sore eyes, sore throat, painful burning skin lesions, okay, lymphadenopathy, eosinophilia, and elevated liver function tests. Those are the big ones. And mucosal involvement, any mucosal involvement. So just pain on urination. So you do need to make sure that those things are documented in order for you to exclude that possibility. Once you excluded all that, you pretty much are on the spectrum of a benign drug rash. Obviously, if they have Stevens-Johnson's, they're going to have oral involvement. If they have EM, they're going to have oral involvement. If they have benign drug rash, morbilliform, very unlikely they're going to have oral involvement. But if it's a morbilliform drug rash and they have DRESS, theoretically they could have LFT. So you do, and that's dressed now. It's not just a benign drug rash. So these are things you want to make sure that you have documented in your note, as well as when you're speaking with your colleagues. So that's why we go into here where it says may have a prodrome of upper respiratory infection, vomiting, diarrhea, malaise for 2 weeks prior to the lesions, lymphadenopathy. I don't know what this HSM is. Pulmonary findings, esophageal findings, hepatitis, all these things you will be able to discover. Now, after the whole thing is said and done and the patient's healed, there are sequelae that you have to pay attention to, and I think I covered those in the TN. There's the TN section of this, very similar. These patients always have oral involvement. Ocular is not infrequent, and the biggest thing you ask is, they may have nothing right then and there when they walk in, but the question is, do you have itchy or irritation of the eyes? Do you have sore throat? Those are the questions you want to ask. Okay, hepatosplenomegaly. Thank you very much. You guys know my notes better than me. Now, these don't typically present with your typical targets, okay? Remember we talked about before, the typical target's going to have that red, then the white, then the red bullseye. These will have kind of an oval shape, erythema, but may not have the rings. Here you'll see here extensive white blistering and ulceration or erosion in the center with erythema, then whiteness, rather than the opposite of red, white, red. These are atypical targets. Blistering, what would you expect this to be? Would you expect it to be flaccid, or would you expect it to be tense blisters based on your knowledge? Yeah, they'd be flaccid, because remember, the blisters in the vast majority of these are intraepidermal, just like PF or PV. Okay, very good. You want to make sure that you get a CBC, because you can have leukopenia, you can have eosinophilia, electrolytes, you can have hypopotassiemia, renal function can be altered, LFTs can be elevated. You should get the IgG for herpes simplex virus. You should culture the wounds and Zank smear in certain areas that are suspicious for herpes infection. You can also get, not infrequently, they may just get Stevens-Johnson's unrelated to herpes, and the wounds can later be complicated by herpes. So if you do end up seeing patients healing well, is doing great, they're persistent ulcers that are punched out, those may have developed herpes. I've seen that on occasion, so you do want to make sure that these, once you stop the insulting agent, you stop the medication. That's number one. Okay, the only thing that's been tested and proven to help the outcome of these patients, and they have areas that are stubborn to heal. Typically, these wounds, remember, they're epidermal. They should reheal, and within 14 days, you have stuff persisting, 10 days to 20 days out that are ulcers. You should consider other possibilities like herpes and Zank, those areas. I have a great picture that I didn't include here. I just thought about it right now. Now, this EM and Stevens-Johnson's, okay, and TN, the biopsy's not, in practice, I'm not talking in theory. We can sit here all day and argue, but in practice, when you sign these out, the pathology is the same along the spectrum. The difference is the clinical. You saw that in the classification, there was no discussion of the pathology, and there's a reason for that. Because the people who see most of this stuff will tell you. They don't see 1 or 2 cases, they see 50 million cases. That's not part of the diagnosis. The biopsy does help make the diagnosis, but TN is a clinical diagnosis overall. So Stevens-Johnson's and erythema multiforme. You need to exclude other stuff using the biopsy. You can snap freeze this epidermis and notice that it's full thickness necrosis in an hour in a Mohs, if you have a Mohs or a frozen lab to set up to do it. But typically what you'll see is full thickness necrosis. Sometimes it's more of a patchy, more subtle if it's early, depending where you biopsied. But here it shows full thickness necrosis. The stratum corneum is spared because, again, it's an acute process, and the inflammation tends to be little. Now, in TN, Stevens-Johnson's more for TN, the brisker the inflammatory process, it's been associated with worse prognosis, okay? You may see subepidermal blister, but that's just from the extensive damage to the epidermis, and focal spongiosis, again, a mixed inflammatory pattern. Number one of all things in these patients, this goes for TEN, is withdrawal of the causative agent. That's the only thing that's been tested and proven to improve this subset of patients. The vast majority of Stevens-Johnson's patients, less than 2% will die. Basically, if you kill a patient or your patient with Stevens-Johnson's died, you probably did it. So unless there's some underlying that the patient has. So understand that less than 2% of patients with Stevens-Johnson's are at risk for death. The vast majority of care is supportive and some wound care. Stop the medication, non-stick sheets, supportive care. The reason why I say stop steroids is because the vast majority of patients, by the time that they were diagnosed in the ER by yourself, because you're an expert, they probably were given some systemic steroids. And systemic steroids, in a large subset of studies, not all of them, have shown to have a worse prognosis when they're treated on long-term steroids for Stevens-Johnson's and TEN. Increased rates of death, actually, okay? So you do want to stop it here. IVIG, depending on how severe, it's controversial. We have really good, I'm not going to get into that in this talk, but we have really good data. We use it. Again, if you want to hear TN, we can get into that one day. Subspecialist consults, that's referring to ocular or possibly ENT if there's, extensive oral involvement or ophthalmological issues. Again, the magic mouthwash, similar kind of spectrum. Be wary of sulfa-containing agents. You do not want to provide that. TN, this is rare. It's about 1 per million, okay, per general population. It's more common in HIV. It's not more severe in HIV, because if it was, then it would be part of the score 10, as you'd know. But it is more common in patients with HIV, not necessarily more severe. This just looks at the more common, the 7 high-risk drugs associated with TN from the Euroscar study in Europe, and you'll see number 1 is allopurinol. This was published when I was a resident. Then you go down from there. Most of these you could see are anticonvulsants. This typically can begin anywhere after 8 weeks or even 3 months after they've received the medication. So patients 2 months out receiving allopurinol does not mean that it's not TN from allopurinol. But typically it's early on, 1 to 3. It starts and does not become chronic. This is not a chronic disease. This is an acute disease. So the clinical presentation is, been taking this medication for whatever amount of time, and now I got this rash that started 2 days ago. Okay, I had this rash and it started a week ago or a month ago. Okay, we already talked about the more common drugs. The mortality depends on the literature that you read. Ours is like 3% at UM, but the mortality in the literature is 15 to 40%. Majority of patients die from sepsis or multi-organ failure. Initially, it's from staph. Later on, Pseudomonas. On rare occasion, it can be from Candida. I'm not going to give you, if you guys want our full, some of you guys have the algorithm for therapy that we use in your survival guide. So I'm not going to talk about the specifics of our algorithm. I'd be more than happy to email that to you. It's somewhat controversial. I've presented our findings a million times, and the only thing that I know definitively is part of the therapy is withdrawal of the agent. Outside of that, pretty much everyone's got their mix and match in what they do and how they manage these patients. You may end up being in a burn unit and they'll fill you up with fluids, or you end up with us and we keep you kind of a little dry. So I don't want to confuse you with our specific protocol, but I'd be more than happy to provide it if you email me. Now, these patients do begin with fever, sore throat. Burning sensation of the lesions. These are questions you want to ask. Headache, fever, chills, nausea, vomiting, anxiety, agitation, confusion. This really, they're scared. This happens. The earlier the diagnosis, appropriate at this stage leads to improved outcomes. Basically, stop the medications, get the steroids off, stop any antibiotics they're on if they're not infected, and then go from there. These lesions are symmetric, they're poorly defined, they may have purpuric centers, develop large flaccid bulla, extensive epidermal detachment, usually spares the scalp, and I'll talk about that when I show you some pictures. Within 3 weeks, so 2 weeks, they re-epithelialize once you stop the medications and they're alive and you don't have any complications. Again, you can have complications like superinfections from viruses or bacteria you need to keep an eye on if the ulcerations or erosions persist. This is just the bad news patient, intubated. This is, thanks, Dr. Curdell gave me this picture many years ago. You'll see just completely denuded skin. This is kind of just show the duskiness. Now, if you biopsy here, just for future reference, you might lose the epidermis. Try to go somewhere that's newer. With erythema, you're going to have enough to call it, okay? The dyskeratosis and the infiltrate you get. But if you get something that's like this, you'll see that it's all kind of denuding away. You're going to lose that epidermis when you biopsy. Stay away from this area. Biopsy possibly one of these areas so the epidermis maintains intact. Flaccid vesicles, atypical targets. This is just, again, bad case. Sloughing of the skin. It's a patient of mine. Similar. This just shows you the oral involvement in PMP versus TN. There's a different ballpark. I mean, a different beast. You can see here on the left-hand side, you see kind of like lichenified, grayish, chronic manifestation of the PMP disease, whereas here in TN, the lower lip is primarily involved because there is some photosensitivity associated with this disorder. And it's just completely denuded on the lower lip primarily. Scalp involvement. This is scalps typically spared. This was a patient of mine that she had lung cancer, had a brain met, received anticonvulsant. I can't remember which one she had. Got radiation therapy to the skull and developed TN involving the scalp and the rest of her body clearly. But the scalp involvement, and there's some association with the radiation. No one's been able to really look at it, but it does happen, and it happens in patients that have had radiation to the skull. This is another patient that had, this patient of Curdell's, different than my case, that the patient had metastatic melanoma, they radiated, and he developed scalp involvement. Super infection, that guy died. The other girl lived. Looked pretty bad, she lived, and then I think like a year later, she fell in her bathtub, cracked her head open, and passed away. It's unrelated to this, but poor lady. She had a lot of bad luck. All mucosal susceptible. These patients have oral involvement, period. They have oral involvement. If they don't, you better look somewhere else if you suspect it, okay? Just make sure that this is pretty much all the patients. I personally have never seen TN without it. I'm not sure if Curdell has. I doubt it. It's just that's part of the picture. They have it. Oral involvement with TN, oral involvement, intubation. Once they're intubated, these patients are not a good outcome. The sequelae, primarily the biggest sequelae that you see are ophthalmologic, where they get, Sika syndrome is number one, and then you'll get some blepharons, etc., and so on and so forth. So that's why you want to get an ophthalmologist early on. Probably the most common sequelae is post-inflammatory pigment alteration. Once they go home, it takes a long time of the skin. GI, you can have strictures and bowel perforation. And that, that's just, you can give them protonics to prevent that. The respiratory part, if you get ARDS or you get bronchial obstruction or pneumonia, this is a bad deal. Once you intubate these patients, things are going to go downhill. There's an acute and later stage respiratory afflictions that you can get. It's long and extensive, probably lecture in itself, but just be wary of this. urogenital, you can get synechia and strictures of the urethra and the vagina. Laboratory, now when you see neutropenia and leukopenia and you have hypothermia in these patients, because remember they're thermal, it's a systemic disease. It's not, once you affect the skin, TEN is a systemic, you're treating the system. You're not really just treating the skin. And their thermal regulation is off, their infection, they're somewhat immunocompromised, so you need to keep that in mind. When these patients become neutropenic or leukopenic and they have a decrease in body temperature, you need to suspect sepsis, okay? Anemia is not infrequently seen, may need a transfusion, thrombocytopenia, DIC obviously, and any chronic or, acute severe illness. Transaminitis, these patients not infrequently can have an associated DRESS or drug-induced hypersensitivity syndrome. Hypoalbuminemia is not infrequent because of third spacing. Pancreatitis, this also can be seen in DRESS. Azotemia, which you can see is one of the score 10 factors. This is just a biopsy. I'm not going to get into this, same as Stevens-Johnson. And these are classic targets versus atypical targets. We talked about that. This, again, we already looked at this. I'm not going to waste your time with this. These are the 7 criteria of the score 10 right when they come in. And this will, the best factor for prognosis are these factors: the glucose, blood urea nitrogen, bicarb, heart rate, malignancy association, body surface area, and age. Remember, nothing here about HIV. More common, but not necessarily a prognostic indicator. You have 0 to 1 of these criteria, it's a 3.2 mortality. Anything greater than 2, 12 to 90% mortality based on this. They repeated this study at the University of Miami and obtained similar results and validated it here in the United States, because this was a French study by Rougeau's group. There are some genetics associated in HLA findings, but most of these patients are slow acetylators, metabolites accumulate and activate T cells. There is a pro-inflammatory cytokine profile associated with increased TNF-alpha, interleukin 6 and 10. This is cytotoxic T cell mediated, so you'll have an increase in CD8 cells within the epidermis. Perforin granzyme, this goes with CD8. It's calcium-dependent pathway. The therapy is the same as you would do with Stevens-Johnson's. The difference is whether you want to add something. I mean, you can and cannot. There's a bunch of things that you can add. We'll talk about that briefly. But the number one thing is this: get rid of the drug. This is the only thing that's been proven to help these patients, okay? This you have. I'm not going to get into it. Now, this basically, remember what we were talking about. This is a systemic disease. So you need to replace the fluids. They're consuming nutrition, so you have to make sure that they're receiving nutritional support. May need hemodialysis. Got to pay attention to their renal function, even though in our group we kind of keep them a little dry. The pain is an issue. It's extremely painful. Need to keep them calm. DVT prophylaxis. This avoids central lines. You can use large bore 18, those 18 gauge needles. You want to avoid this because these tend to be a nidus for infection and sepsis in this subset of patients. Also, a lot of CVPs have antimicrobial coatings, and who knows what they got before and if there's a cross reaction that you can get. But you have this as well. Again, if you want our protocol, I'd be more than happy to send it to you. The oral care is the same. You have tons of wound options, care options, topical antimicrobials. You do want to avoid those containing sulfur. Topical moisture retention ointments, like I always forget the name of that stuff. It's a yellow with, I can't remember the name. Antimicrobial dressings like Acticoat, we've used that. I had a patient recently that I just didn't want to move. This was not recently, a couple of years ago. I just didn't want to move her, So we basically used a silver dressing called Acticoat. She was erythrodermic, swollen, edematous. She only had few areas that were denuded. I mean, if you touched her and pulled her skin, it would all come off. But in order to reduce the the movement, that active coat can last and stays active for 7 days. The only thing you have to use is water on it to keep it activated and moist. We just set those little pads on her and we kept her still and a little bit, not sedated, but well covered for her pain. You do not want to debride these patients, okay? Do not debride these patients. You will actually increase their fluid loss. So it's, remember, when you look at, I mean, you saw those biopsies. When you look at a burn patient, okay, and you burn the skin, all that stuff is necrosed. The whole skin is necrosed, the whole epidermis. That right there is just calling in for bacteria to affect it. Biological dressings like Apligraf, these are like 2 or 3 epidermal layers, you know, it's very thin, few cells act there alive, and that's why it works. It's the same with this. If you notice on those biopsies, there are live keratinocytes present throughout that epidermis that's, you know, has a lot of dyskeratosis. So just because you have full thickness necrosis doesn't mean that that's not a viable biological dressing and doesn't retain and protect the skin. So you do not, I repeat, do not want to debride these patients. Many burn units do. And I mean, I know that for facts. I worked in a burn unit, and that's their #1 thing. Do not debride these patients. What we do initially, we haven't done this in a while. I have to say we haven't kind of steered away from this, at least the last couple patients I've seen. But we'll use these giant soft sorb dressings that don't stick, and we mummify the patient. Basically wrap them up, and then we use a 0.5% silver nitrate solution poured on it to protect it from infection. And we, you know, even after we don't debride, we do not debride. And this speeds the reepithelialization process. This kind of just shows the soft sorb being applied, and then we pour it on the patient. We haven't done this in a while. Here's a silver nitrate solution. Now, let's look at the systemic treatment options. All these are viable, I suppose. I don't use any of them, but thalidomide will kill your patient, and steroids have been associated with killing your patient. So thalidomide, there was a trial done on this. The trial was discontinued because too many patients were dying. It's not a viable option. Steroids, for whatever reason, many reasons, and there's a bunch of theories, you can read them if you wish, are not used. These others have been used. We don't use any of these. We use IVIG. I'm not going to get into the extent of this. This just talks why, because there's a whole theory between the fast ligand interaction and activation of keratinocytes for apoptosis. This blocks that so that the cells do not undergo that. The other thing with IVIG, it acts like an incredible intravascular colloid, so it kind of expands intravascular space. Post-TEN care, you basically have to do all this stuff, sunscreen, ophthalmology. The one thing, if they do have an associated DRESS syndrome, keep an eye on their thyroid function, because months later they may develop thyroiditis. Now I'm going to talk about this because this is as severe, I think, as TEN. This is slightly different than DRESS. This is the drug-induced hypersensitivity syndrome, has a later onset, lasts longer. Okay, it's kind of got a mononucleosis kind of symptom, and it has some pretty bad issues that can arise that we'll look at. It typically occurs, you know, within 2 months of starting a drug. The most common culprits are the anticonvulsants, but in addition, you know, allopurinol, minocycline-induced DIHS can occur, but the big culprit are these anticonvulsants. Now, these patients can present, there's no specific skin rash, okay? It's like DRESS. These two can have macular papular, blistering, look like TEN. They'll all look the same. They all kind of have, they don't look the same. They can present clinically very differently, okay? The issue with these two is the clinical course and the multiple organ involvement and the detection of herpes reactivation. That's the difference between this subset of patients and benign drug rashes and TEN, for example. this just shows that, you know, you can have like a TN-like picture or even like a morbilliform picture. These two patients had drug-induced hypersensitivity syndromes. Again, you can have any of these exfoliative or EM-like, any of these eruptions can occur in this subset of patient. You can have an overlap of drug-induced hypersensitivity and TN. Late onset is characteristic of DIHS. Here it just shows that the duration of administration until appearance of adverse drug reactions later. And this is basically how you diagnose this, because this is the question. You're like, what is DIHS, right? And I'll tell you a little bit about the difference with DRESS as well. But any rash of the skin developing, you have to have the 7 criteria of these, all of them is slam dunk, okay? Done. Drug-induced hypersensitivity syndrome. If you have 5 of them, this is atypical, then you fall into an atypical or light, like DIHS light, okay? And you basically can get any rash, as we talked about, starting within 3 or greater than 3 weeks, so after the 3 weeks of starting the medication. Prolonged clinical symptoms after discontinuation of the causative drug. This is similar to DRESS. You got to keep them on long-term steroids for a while. Fever is greater than 38 degrees. Liver abnormalities. So the liver transaminitis, you'll have greater than 4 times that of the normal value. Okay, 2 times doesn't mean anything. 3 times questionable. 4 times you're already walking into the spectrum. CBC abnormalities, at least one of these, a leukocytosis or atypical lymphocytosis or eosinophilia, lymphadenopathy, and then herpes HHV6 reactivation. Now, although DRESS and DIHS are mistakenly synonymous, they're not identical. DIHS is severe, more severe than DRESS, and DIHS has reactivation of herpes, human herpes virus 6 in the vast majority of those patients, okay? Whereas not common in DRESS. It'll happen 2 to 3 weeks. The reactivation occurs 2 to 3 weeks after the onset, sometimes resulting in like a mono type picture, the fever, the hepatitis, the fatigue. They can also get reactivation of CMV, EBV, and HHV7. Now, EBV and HHV7 have no clinical implications. It doesn't matter. Who cares? So you have reactivation. CMV, on the other hand, does have associations. It can cause myocarditis. So a patient with DRESS, they're getting treated. They're doing great. 6 weeks later, start with chest pain. You have to suspect that the patient has CMV-associated myocarditis. This kind of shows it here. You'll see that they start with infectious nucleosis-like symptoms, the fever, hepatitis with reactivation of HHV6. Later on, you can develop hepatitis, pneumonia, GI bleeding, and myocarditis secondary to CMV. This just talks about once you have recurrent transient fever. So the patient was doing well, was treated, starts getting the fevers again the rash, and develop underlying organ findings like myocarditis. You can find, this was just a side note, you know, where can you see HHV6 reactivation? You can see it in GVHD, measles, dengue, DIHS, and DRESS. That's just more of a board kind of thing. Because, you know, you always hear about HHV6. You know, like, okay, where is it associated? Not necessarily the cause, okay? I don't want you to think that I'm saying HHV6 is the cause of any of this. The reactivation complicates it, okay? That's the question. It's not the HHV6 cause it. This, like DRESS, hardcore systemic steroids for long term, 2 months, okay? The only anticonvulsant that doesn't have this is valproic acid. Asked about family history, not infrequent. I put this C pharmacokinetic genetics charts. I have these charts that talk about, I took them out because it's just beyond the scope of this talk. There are lymphotoxicity stimulation assays. That was also part of this talk. I removed it. You know, if you're interested, I can send you the list. Remember, thyroid function, autoimmune thyroiditis can occur about 2 months out. Mortality is approximately 15%. So just keep an eye on that. Now let's do pemphigus, and then do you have any questions on this? Because this is pretty dense. I'm going to do pemphigus because I can fly through it. And then I don't have as much the next time. Any questions? First years, please ask questions because you're going to be calling me. And if you don't tell me this stuff, I'm going to get pretty upset. Yeah, you could send it out just like virology. You just put HHV6, take it from the blood. It's the same as IgG, IgM for HHV6. The question is there HHV6 lab test, and the answer is yes. So Sam, the man, I'm assuming that's Ecker, Dr. Ecker. Dr. Ecker, when you call me about a consult, I'm assuming that I'm going to get all the answers that I want. None of this rashy rash, nothing, right? Okay, just messing with you. Okay, let's go through pemphigus since no one wants to ask questions. I'll make this quick. Pemphigus, just basically autoimmune blistering disorder. These patients can be admitted because they can be super infected, dehydration, the diffuse nature of the disease, all that stuff. May need IV steroids to improve them quicker and some IV antibiotics. 50 to 60 years old, a little bit younger than the BP subset of patients. Checks recent medications because there have been associated pemphigus induced by medications, drug-induced pemphigus. Can be recurrent, persistent, pruritus, burning, especially in PF, pemphigus foliaceus. Look for both cutaneous and mucosal lesions. This is just the spectrum of pemphigus, which again, I'm going to just highlight and go over this stuff because this is a whole subset of lectures in itself. I just want you guys, when you see the patient, you have a differential when you're evaluating blistering dermatosis throughout this whole thing in the consult, now early on, not a year from now after you're done with your first year. Pemphigus vulgaris, foliaceus, they're drug-induced forms of pemphigus, PMP, IgA pemphigus. These pemphigus subset of diseases are intraepidermal encapsulitic disorders, primarily desmoglein 3. However, desmoglein 1 is also affected on occasion in PV. PF, it's primarily desmoglein 1. These are flaccid. We talked about that, just kind of coming off, laying down flat, not tense. They can appear anywhere, very painful, Nikolsky positive. Erosions, oral involvement is painful, not infrequently seen. Now, pretty much all this stuff is done to make sure they're doing okay and they don't have anything underlying. It's not really for pemphigus in itself unless you suspect that they're septic. Then you should do cultures in addition to all this stuff, okay? But you do want to know their electrolyte status as far as their fluid balance, CBC. Some of these patients can be anemic. Again, if they're infected, might be leukocytosis. Renal function can be impaired if they're dry. Liver function test, typically not involved in PV in itself. And then in addition, these studies are done for drugs that we'll talk about, dapsone and azathioprine in the near future. This is an intraepidermal acantholytic dermatosis. There's a huge spectrum of diseases that you'll be reviewing over the year. But you'll see here it's primarily suprabasilar, okay? Suprabasilar. So it's above the basilar layer, right above it, okay? The direct immunofluorescence shows this chicken wire, basically IgG deposits between cells. And you guys saw direct immunofluorescence lecture earlier on this year. I'll give one later. So I'm not going to get into this, but IgG is predominant. IgA on occasion C3. That's not no. That's wrong. In direct immunofluorescence, we use the SPLUD. I'll talk about this later too. Monkey esophagus as well as RAP ladder. And this will help in determine disease activity, therapeutic response, and differentiation from other pemphigus groups such as paraneoplastic pemphigus. This table, I'm not sure if you have it. If you don't, I'll send it to you in your handout. This just basically goes through the antigens that are involved, desmoglein 3, for primarily mucosal pemphigus vulgaris. There's the desmoglein complex theory that's in the books. Again, that's more for a more detailed talk on pemphigus, but desmoglein 3 for primarily mucosal mucocutaneous pemphigus vulgaris, desmoglein 3 and 1, and for PF, it is desmoglein 1. This is the huge spectrum of antigens that are being attacked in paraneoplastic pemphigus that you will need to memorize. This just shows that superficially, the affected areas in pemphigus foliaceus are superficial epidermis, whereas in pemphigus vulgaris, it's the suprabasilar layer with deposits of IgG on direct immunofluorescence. Now, intraepidermal dermatoses that are acantholytic, that are non-immunobullous, Grovers, Derriers, HSV, Haley, friction, incontinentia pigmentii, impetigo, staph scalded skin. You want to keep these in mind. And you don't want to end up getting a false positive direct immunofluorescence and a kiddo has impetigo, and it's been called pemphigus foliaceus. We have seen that. For treatment for pemphigus, it's basically wound care, okay, non-stick sheets. You can use steroids. But it's steroids 1 milligram per kid per day, plus all the prophylaxis that you need for steroid therapy. And then in addition, adding one of your favorite steroid sparing agents, okay? The dosages vary, and we'll talk about each one like we did last week, mycophenolate mofetil, and their dosages for these problems, for this problem. Magic mouthwash, we use just this concoction right here of steroid, antifungal, bicarb, and the antihistamine. You can use hydrogen peroxide and water 1-to-1 and lidocaine as well for pain. Okay, so there we are. I think we're going to stop here because it's pretty dense. At this point, it's been an hour. It's a lot. If you have any, we'll start at pemphigus foliaceus. The rest of it's pretty straightforward. Do you have any questions or anything I can answer from here on? I'm going to stop the recording.